Hi, I'm Alexander Perdomo, a postdoctoral fellow at the Hopkins Spinal Fusion Laboratory. I'm going to talk about a new biomimetic delivery system of PDGF and adipose-derived stem cells in a biodegradable graft for enhancing spinal fusion that we test in our rat model. We treated culture expanded adipose stem cells onto polycaprolactone or PCL scaffolds, along with PDGF-loaded heparin-conjugated decellularized bone matrix or DCB particles. Once the grafts were loaded, they were implanted through a posterolateral approach. 8 weeks after surgery, we assessed the fusion status of 5 experimental groups, including 2 scaffold controls with and without DCB, and 3 treated groups with addition of PDGF alone, stem cell alone, and both PDGF and stem cells. In the micro-CT scan, we found fusion masses in all the PCL DCB groups, while no bone formation was observed when the PCL scaffold was implanted along without DCB particles. When we compare the fusion bone volumes among the bone-forming PCL DC groups, we found a higher bone volume in the PDGF group without additional stem cell transplantation. In the histology, we found more ossified tissue in the interface between graft and transfer processes in the treated groups, again, more in the PDGF group, also showing expression of RUNX2, CD31, and osteocalcin in these groups. In summary, this new biodegradable PCL DCB graft combined with osteoinductive DCB particles promote adequate bone formation to achieve spinal fusion, and the combination of the PCL and PDGF further enhance bone formation. Thanks for your attention.
Hi, I'm James Foley. I'm representing the SUE group at Northwestern University, presenting some research on sex-based differential response to BMP2 in a rat spinal fusion model. Sex-based differences in clinical outcomes after spine fusion have been investigated with conflicting results. Clarifying whether there exists a sex-based differential bone regenerative response could improve and personalize patient care in the setting of spine and other orthopedic procedures requiring bone healing. We sought to assess and validate the presence of a sex-dependent bone regenerative response to BMP in the rat spinal fusion model. 28 male and female Sprague Dawley rats underwent L4 to L5 PLF with bilateral placement of 5 micrograms of BMP2 on an absorbable collagen sponge. Bone regenerative response and fusion were assessed 8 weeks post-op via blinded manual palpation, and micro-CT imaging was used to further evaluate newly formed bone. As expected with a BMP dose of 5 micrograms of implant, radiography and manual palpation showed 100% fusion rates for both sexes. Using our modified fusion scoring system outlined in panel A, fusion scores were lower in females relative to males, reflecting a greater number of segments fused in male rats. Panel B shows representative micro-CT images for each sex. Although females had significantly lower total bone volume, they had significantly greater bone volume fraction, as shown in panels D and E respectively. Interestingly, however, new bone in females had twice the trabecular number, which was a likely contributor to the higher bone volume fraction in females. This work suggests that female rats produce denser, but a lower volume of new bone relative to males in response to high-dose BMP. The detailed interactions between sex hormone signaling and the BMP pathway should be further investigated in light of these findings. The sex-based differences in BMP response in this animal model may have clinical implications for human subjects. This study demonstrates that sex-based factors may influence both the quantity and quality of bone formation in patients receiving BMP2 for a variety of orthopedic applications. Thank you.
Hi, I'm Sarah Bhattacharjee. I'm a third-year medical student at the University of Chicago Pritzker School of Medicine, and today I'm presenting preoperative lumbar epidural steroid injections within 6 weeks of microdiscectomy are associated with increased rates of revision. So lumbar epidural steroid injections, or LESIs, are widely utilized in the management of lower back pain. However, recent studies have been shedding light on potential negative effects of these injections. And so defining a safe interval for their use preoperatively is of particular importance. We investigated the effects of preoperative LESI timing on the rates of recurrent microdiscectomy using PearlDiver, a national insurance claims database. So we first identified all, if I can get my math to work, all microdiscectomy patients within the national database and stratified them based on their history of LESIs within 6 months prior to surgery. We further broke down patients who received these injections into biweekly timing cohorts based on their most recent injection prior to surgery and compared them to a control group of patients who received no injections within those 6 months prior to surgery. Risk factors were determined using univariate analyses, and those that were observed to be significant were then included in a follow-up multivariate analysis, which sort of moving around the abstract here, which determined that a history of tobacco use, patient age over 60 years old, and injections administered within 6 weeks prior to surgery were all independently associated with increased rates of revision. So further research is definitely necessary in order to better understand this relationship, but we hope that this can help delineate a safe timing interval for the use of these injections and to better protect our patients. Thank you.
So hello, I'm Alex Ballatori. I'm a second-year medical student at the Keck School of Medicine, and this is my project on the analysis of postoperative outcomes of SI joint fusion to treat sacrum pain, sacroiliitis, sacral instability, or spondylosis. To do this, we used the 2016 National Readmission Database, and we identified 1,272 patients who received an SI joint fusion. From these patients, we then separated them by non-overlapping diagnoses and found 282 patients with sacrum pain, 536 with sacroiliitis, 135 with sacral instability, and 155 with spondylosis. We looked at quite a few outcomes, but today I will just touch on non-elective readmission rates, infection, and novel lumbar pathology. So if you direct your attention to the left side, the far left graph, we see that in terms of non-elective readmission rates, sacroiliitis had these 17% non-elective readmission following their SI joint fusion. And this was a significant difference compared to all of the diagnoses. And for your reference, at the bottom here, does my mouse work? Yep. So sacroiliitis patients had on average 1.8 non-elective readmissions, whereas the second highest group, sacrum pain, had only 1.24. Next, if you look in the middle of the screen, in terms of novel lumbar pathology within 90 days of fusion, sacrum pain had significantly higher rates of novel lumbar pathology. And then if you look below that, in terms of infection, sacrum pain also had the highest rate of infection within 30 days of receiving the SI joint fusion. So in conclusion, sacroiliitis had the highest rates of non-elective readmissions, and sacrum pain had the highest rates of novel lumbar pathologies within 90 days, as well as having the highest rates of infection within 30 days. So in the future, we will incorporate more years of NRD, and then we also hope to analyze by surgical approach. That's all I have for today, and I thank you very much for having me.
My name is Dr. Amrit Khalsa. I'm an assistant professor of orthopedic surgery at the University of Pennsylvania in Philadelphia. I'm going to talk about an abstract today entitled "The Effects of Marijuana Use on Lumbar Spinal Fusion." I think it goes without saying, marijuana is kind of the new frontier for surgery in general, and what effects it has on various surgeries, particularly lumbar spinal fusion, is not well defined at this time. So we did a retrospective cohort study looking at 102 patients that underwent 1 and 2 level TLIF procedures. Pretty much 50-50, 50 patients that reported daily recreational marijuana usage, self-reported, both preoperative and postoperatively, and then 52 patients that denied marijuana usage. And this was over approximately 1 year time period. Then we looked at data collected, including procedural data, demographics, adverse events, and outcomes. We had, on average, about 17 months of follow-up for those 102 patients, and then looked at ODI preoperatively 6 months and 12 months, and then radiographic fusion assessment via some validated parameters. Outcomes that we found, first off, we noted that there was a significantly slightly lower age in the marijuana usage group by approximately 9 years, and there was a shorter length of stay, which was obviously probably some bias related to the lower age. But what was interesting was we found no effect of marijuana usage overall comparatively on ODI, on overall fusion rates, on complication rates, and return to the operating room. So overall, found that marijuana usage per this retrospective study had no effect on lumbar fusion rates and complication rates overall. I'd like to thank my authors, co-authors. Thank you very much.